get this going.
Welcome everyone to our session on interprofessional leisure education, leave no trace for individuals with acquired brain injury. I'm Dr. Christina Brown-Maquillo, and I'll be introducing you to my colleagues that will join me in this presentation. Today with me from the Department of Recreation, Parks, and Tourism Administration, we have Dr. Erik Luvaas and Dr. Jamie Hodgman and Dr. Darla Hagee from Speech Language Pathology as well. We'd like to share with you a few of our learning outcomes today and hopefully target some of the reasons why we're all here to learn. And participants will be able to identify best practices in interprofessional education and collaborative practice. You'll also be able to describe the curriculum related to Leave No Trace and nature-based engagement that's modified for adults with aphasia. And finally, we hope that you'll be able to identify community-based volunteer opportunities within your own communities for adults with disabilities. A brief description of our session. Today we're going to include recreational therapy and speech-language pathology as a joint collaborative presentation involving interdisciplinary students and adults with acquired brain injury. Our proposed curriculum will be presented at the end to support nature-based engagement and leave no trace practices for adults with ABI resulting in aphasia. The program today will conclude with opportunities to connect participants with associated environmental volunteering in your own communities. We'll also include a plan for post-COVID programming.
All right. Thank you for that introduction. I'm Darla Hagee, and I'm going to lay a little bit of a foundation of our pilot study so that you have an understanding of how it's grounded in the literature and in best practices. So to begin, our pilot study is embracing a social model approach to disability. And if you want to go back to the previous slide, that would be great. The social model approach to disability is all about how an individual engages in their life in terms of quality of life, life participation, and the professionals and volunteers around with their family members all support reducing those barriers that exist to their ability to participate meaningfully into life. This is obviously in contrast to the medical model of disability, which our healthcare systems are built upon. So the medical model of disability, in contrast, is where you go to be healed, to be repaired, to make that which is not functional or not normal, normal within normal limits again. The social model just embraces all types of disabilities because the perspective is if we all live long enough, we will all be living with a disability. Okay, so next slide. At the turn of the century, in this country, individuals, the mortality rate was due to acute issues. And so then, because of a lot of the promotion and the government programs that were laid out, including water treatment, water sanitization, childhood vaccination programs, and much more, Americans began dying not from acute issues, but rather from chronic conditions. For example, chronic obstructive pulmonary disease, COPD, diabetes, hypertension, cancers, arthritis, etc. So the World Health Organization actually acknowledges the impact of living with chronic conditions on members of a society. And in 2002, the World Health Organization published a document entitled The Innovative Care for Chronic Conditions Framework. And in this document, it recognizes the role that community-based programs play in supporting the health and well-being of the citizens of a community, and that there's actually this relationship between patients and families, or clients and families, and the healthcare teams, and then the community-based programs themselves. So next slide. And then this next slide basically lists the emphasis of community-based programs, and that there is obviously a significant need for community-based programs because all of healthcare is built around and reimbursed for acute care services. So next slide, please. In taking action in creating or implementing community-based programs, according to the WHO, we want to keep in mind certain goals that they outline for us. And they are listed here. I want to call your attention to just a few of them, that the role of a community-based program helps individuals and their loved ones to transition from that acute care perspective, which generally means that they're going to get healed, they're going to recover fully, and if it's a chronic condition, we know then by definition that it's going to be something they're going to live with the rest of their life. And so it helps those family members make that transition into living at the chronic stage. In addition, it builds a more integrated, seamless healthcare system where individuals move through the different levels of care at the acute stage and then move into the chronic stage. Community-based programs focus all their attention and intervention on the individual as well as their families in supporting them getting back into life, participating in the community, improved quality of life, and acknowledging any barriers that might exist and decreasing those barriers. And then there's an educational component, which is emphasizing prevention of further chronic conditions, furthering the progression of a disease process, etc. So next slide. And then, again, our pilot study also incorporates best practices in terms of interprofessional education and interprofessional collaborative practice. So interprofessional education, or IPE for short, is defined as when two or more students or professions come together to learn about, from, and with each other. And this is all about building effective collaboration as well as improving health outcomes for individuals who receive services. Then collaborative practice provides where multiple disciplinary healthcare workers from all sorts of different professions provide comprehensive stellar support to individuals and their loved ones, thereby being able to deliver the highest quality of care across settings. And this is also published and reported from the WHO at the very top and all the way down at multiple organizations and healthcare policymakers in this country as well. So next slide. This is published by the Institute of Medicine in 2016, and I include this slide so that you can see, if you look at the blue box, that interprofessional ed, or IPE, is designed to begin being introduced to students across healthcare and across all disciplines, actually, minimally, and then at the graduate level, it even increases more. And by the time you're a working professional, you can see, based upon that figure, that half, at least, of your continuing education opportunities should be all about interprofessional education and increasing that sense of teamwork into your practice. Next slide. The goals of IPE and interprofessional collaborative practice are fairly simple. They're very direct. It's all about preparing a collaborative, practice-ready workforce that will improve healthcare outcomes for all individuals receiving services and their loved ones. And it's designed to teach the professionals how to work in interprofessional teams and how to be effective in this role. An analogy would be that, let's say you recruited the best soccer players from around the world, but you never had them practice together. You just put them together for the first time in a game. How would they perform? probably not very well, even though they were the best around the world, the best players. Why would that be? They are not accustomed to working together on that particular team. Building teams, working together requires time, building trust, etc. So this is what IPE is all about. Next slide. So that you also know, there are some learning experiences that are good, they're valid, but they don't qualify as interprofessional education. And here's a listing of some of them. For example, learning near. If students from different healthcare professions come together and they receive the same learning experience, but they don't have the opportunity to interact with each other, it's not IPE. Or if you have another professor come into your classroom that's from another discipline and provides a guest presentation, that is valid learning experience, but it also does not qualify as IPE. Or if you go and you shadow another professional from outside of your particular discipline, that's a great learning experience, but that also is not IPE. IPE requires, by definition, that the individuals involved need to learn about, from, and with each other. Next slide. So for our pilot study, this is how we're integrating interprofessional collaboration. We're bringing together recreational therapy students as well as speech-language pathology students. This is a wonderful combination. Rec therapy and speech therapy work well together. There's so much overlap, and they can truly support each other's goals, and which provides better care, better services, and better outcomes for the populations that we serve. In this particular pilot study, the rec therapy students serve as intervention leads. They facilitate the programming as well as volunteerism. The speech-language pathology students serve as trained communication partners, and they will be able to identify ways to create improved communication access for those individuals who are participating and model the literature-based communication strategies. Next slide. So the population that our pilot study is embracing are those adults with acquired ABI or acquired brain injury. And ABI is an injury, obviously, to the brain. It is not hereditary. It was not induced by birth trauma. It has occurred sometime after birth. And for the purposes of our pilot study, it's going to be adults is when that acquired brain injury occurred. Next slide. There are multiple etiologies to acquired brain injury, and we can organize them in two very large, broad categories. Traumatic brain injury, also referred to as TBI, and NTBI, or non-traumatic brain injuries. And so in front of you are some lists of what types of situations fall under TBI versus non-TBI. Many of our members in our pilot study, or the participants, will have experienced a non-traumatic brain injury. They'll have had a stroke. Some of them will have a progressive disorder, like one of the many different types of dementias, or some of them have a TBI, traumatic brain injury. So some of them will have had a fall, whether they've just fallen and hit their head on a sidewalk, or if they fell off a bicycle and hit their head, or if they had a motor vehicle accident. So these are some of the different etiologies of ABI, and specifically for our pilot study. Next slide. So as you work with this particular population, it's important to recognize that they have had, regardless of whether it's a TBI or an NTBI, they have been through a very long journey to get to the community-based program level. And so the slide, as well as the next slide, kind of helps to outline that journey for you. This population begins at the acute care, so they might have started in the emergency department, then they transition up to an acute medical floor. Once stabilized, they can be transitioned into the acute inpatient rehab in a hospital or medical facility. Once they're done there, they're often transitioned either to home, where they can come back and have outpatient therapy, or they may be transitioned instead of home, they're going to a skilled nursing facility. And you can see the different types of interventions they're receiving at these different levels of care as outlined on this slide. Next slide, please. So some of these adults are young, so they'll be going back to school, and so there's that transition of back to school. And other adults, when they finally are transitioned back to home permanently, then they're going to be needing and looking for resources, including community-based programs. And community-based programs may provide one or all of the following that's listed there. It's about providing them with education, about prevention of further injury, learning how to self-advocate, how do they manage their chronic conditions and all the issues that arise from those chronic conditions. So it's a great opportunity for them to not just learn from the volunteers or the professionals that provide community-based programs, but they're also learning from their peers. They're learning for others who are also walking out the journey. And this is a very powerful method of education and training. Next slide. It's also important to remember that there are many barriers for individuals who have ABI to participate in these programs, or even just to participate and get back into life. They experience reduced social networks. Social networks is not a social media site. It is actually in the literature. It refers to your social networks are all of your friends and acquaintances. It's all of your interactions that you have with people around you. And we know, as evidenced in the literature, that many times, most of the times, our social networks are disrupted and they almost like collapse into themselves. And so this population is at risk for being socially isolated. You may ask, what difference does that make? And that is, there is a robust literature across countries and around the whole world that the strength of our social networks helps us to live longer. We live longer when we have a strong social network support around us. And not only do we live longer, we're healthier during those years than if we don't have a strong social network. So that's how powerful our friendships and our supportive circles that are around all of us, especially this population who's had an ABI. Many times this population, they've experienced a loss of employment. They're not able to go back to work. So they have reduced income, they may have transportation issues, they may not be able to drive anymore. There's often accompanying physical deficits as well as possible cognitive deficits. That means that they may not even be able to go back to school if they're college age, for all of those reasons. And for many individuals with ABI, they may present with chronic communication deficits. Next slide. And so one example of a communication deficit for this population, and it's one that we're targeting in our pilot study for adults with ABI, is the presence of aphasia. And this particular picture it was framed in a poster in my office as an outpatient clinician. And all the individuals that first came to my office who have aphasia used to just point to that because it was so meaningful to them. I think it captures the essence of what is aphasia beautifully. Next slide. So what is aphasia? Aphasia is an acquired communication deficit, specifically about language. And so for language, there's 4 modalities. One is being able to think of the word and say it. Another is to be able to understand what people are saying to you. A third language modality is ability to read. And the fourth would be the ability to write. So speaking, understanding, reading, and writing. those are the 4 language modalities, and aphasia crosses all 4 of those modalities to either from mild all the way to profoundly impaired. For any individual who speaks more than one language, so if they're bilingual or polylingual, aphasia will impact all of their language systems, and that includes American Sign Language, or ASL, because that is also a language. So it's not helpful to opt to teach someone ASL after they have aphasia, because it also is a language system. So you can imagine how devastating the acquiring or having aphasia would be to an individual. It's typically chronic. It lasts the rest of their life. How do you connect with others? How do you get your needs met, etc.? Next slide. And it's also important to know these are a few more touch points about aphasia. There are 2.5 million persons in the United States who are living with aphasia, they and the loved ones around them. And most of the time, no one's even heard of this. My belief, and my colleagues who are also aphasiologists, we believe it's because the individuals who have aphasia cannot advocate for themselves because their ability to communicate has been decreased or eliminated. So this is the population that we're targeting, individuals with aphasia secondary to an acquired brain injury. Okay.
All right, thank you. Similarly to the inclusion of community-based education and participation, one of the cornerstones in recreational therapy education is the leisure ed model. If there's any students in the audience, I'm sure you're familiar with it or have memorized it or will shortly, because we talk about it a lot in rec therapy education. But it's a model that takes participants from along the continuum of care as well, from acute care. If you look on that sort of far left side, and I apologize if the image is blurry to you, but if you look on the far left, you'll see that it's very therapist-driven, that most of the outcomes are based in improving function in more of an acute setting. And as you move up through the continuum of the leisure ed model, the emphasis on sort of supervised care by a therapist starts to decrease, and participation in communities and independence from participants, such as those that will be in our pilot study with aphasia, begins to increase more. And so for our study and the curriculum that's being developed, we're talking about sort of the intersection of leisure education and recreation participation, focused on being in the community and not in an acute care setting. Similarly, this is another model that shows leisure education content based on that model. And the components that we're talking about and utilizing in this program will be those in that secondary white circle. If you look at the sort of at the top of that circle, it says components in that box. And so the items that will be addressed through this program will be things like exploring opportunities in the community, as well as for volunteerism, and then other sort of more interpersonal outcomes that come from developing relationships, developing community networks with individuals that are participating, developing an ethic that could be a work ethic, acquiring knowledge, gaining skills, managing challenges, and becoming self-aware. And none of these are really addressed separately, but they are all outcomes that happen when individuals are engaged in community-based programs that are given the opportunity to connect with peers, connect with recreational therapists and leaders in the field to carry out these programs.
All right, so when we're talking about the need for this nature-based community leisure education program, we have to look at leisure. So leisure is what we do in our free time. So there's two different types of leisure. There's serious leisure and casual leisure. Now, for most of us, we would never even think that that this exists. But really, we're trying to look at hobbies, volunteerism, and the reason why people are motivated to participate in their community as well as with their peers. So we're looking at creating this opportunity for these individuals due to the lack of either access, knowledge, or ability, and creating more inclusive opportunity for participation. Next slide. Perfect. So looking at this, we also think about the optimal leisure lifestyle. So I'm sure for most of you, obviously during this pandemic, our leisure lifestyle may have shifted a little bit, or we've had to adapt to a new leisure lifestyle. But our optimal leisure lifestyle is really being integrated into a community, having a group of people where we are involved and we're connected. Again, looking at a study from Harvard where they looked at long-term lifespan and health and wellness, they found out that connection and relationships was really what allowed people to live a long, healthy life. So that optimal leisure lifestyle is really essential for a person's increase in their quality of life as well as participation in their community, which is why we think this is an important component of our program.
Thanks. And just a segue before we talk about some of the reasons why we're focusing on a nature-based intervention curriculum. It was mentioned that developing an ethic is also important, and for our particular intervention program, we're talking about an outdoor ethic using leave no trace principles. And so the hope is that this will tie into or help someone develop a leisure identity around being outdoors with others and participating with others and developing a social network. Many of those issues that Dr. Haiti mentioned. So the reasons to center this intervention in nature-based activities are for a couple of reasons. There's a couple of theories that support it. For one thing, attention restoration theory is one of those theories. And Dr. Brown-Bakuke, you could just go ahead and give me the bullets. So attention restoration theory posits that we have a limited amount of directed attention or voluntary attention available to us throughout our day. And as our day moves on and we have decisions to make, we experience decision fatigue over time, and it becomes more difficult to engage in tasks that require things like cognition to speak and understand others, engage in social interactions. And what the research demonstrates is that nature has the ability to restore some of these cognitive capabilities because it provides us an inherently fascinating stimuli to look at, such as being in this forest environment. There's not a whole lot of stimulus that we have to negotiate in that environment. It's a relatively calm natural environment. And it activates our involuntary attention or indirected attention. So it gives us our directed attention kind of a break. And let's go to the next bullets. Great. So some of the evidence to support this theory you can find in the literature. More than 20 studies have shown that people spending time in nature versus built environments increases the attentional performance. Some with as little as 10 minutes of engagement in the natural environment. Other studies have looked at specific disorders such as attention deficit hyperactivity disorder and found that as little as 20 minutes of walking in the natural environment is as good as using ADHD medication in terms of the symptoms that they experience. And we've also seen some literature that suggests that, these little micro breaks of 40 seconds looking at nature, looking out your window in between Zoom calls, for instance, can improve your attentional capacity. So the evidence for attention restoration theory has many implications for learning and memory, focusing on tasks, blocking out distractions, and improving positive behavior towards others, which is really relevant to this population that we're talking about. Individuals experiencing aphasia, may have difficulty with sensory processing in terms of language, and so this may have some effect, although there's, as of now, not evidence that we know of to support this. So this is a reason why we're looking into this population. It may also have implications for dementia care, other learning and attention disorders, and I believe there's one more, and psychiatric settings, of course. All right, next slide, please. Oh, yes, and your staff. It's really good for everyone. So the theories and the evidence to support them really are can be applied to any population. So it's not specific to aphasia. The other theory that supports the use of nature-based interventions is the stress reduction theory. This is a different theory that attempts to explain why we receive some benefits from being in nature. And it's a psychoevolutionary nature connection theory based on the biophilia hypothesis that as human species, we are inherently interested in other life forms and attracted to other life forms. And that nature provides us a positive emotion through the perception of safety because we have evolved in these environments over thousands of years. And so we have this inherent connection to natural environments. The theory is really a psychophysiological stress reduction theory, so it's less about how our cognitive capacity is impacted by nature and more about what happens to us psychologically and physiologically, and how our stress response can be reduced by spending in nature, which also has some impacts on our cognition ability. Next slide, please.
Don't you just want to take a minute and stare at the sloth and his happy little face?
It's very calm and collected.
Totally. I love sloth faces. Okay.
So some of the evidence for supporting stress reduction theory, similar to attention restoration theory, there's been a lot of studies looking at people who spend time in nature versus urban or built environments with less nature, less flora and fauna available, less biodiversity. And it's not surprising that people who spend more time in those natural environments in these experimental studies have improved mood, well-being, self-reports of well-being, self-reports of meaning in life and mindfulness. And we see physiological improvements as well in blood pressure, release of stress hormones is reduced, reduction in inflammation markers in the immune system, and improvements in immune function, and optimization of the autonomic nervous system through measures of heart rate and heart rate variability. It's been seen in a few studies that, for instance, if you live greater than 1 kilometer away from green space, the population in this study showed higher odds of stress and poor health outcomes. So there's some epidemiological evidence to support being in nature and engaging in nature as well. And frequency also seems to matter in some studies. One in particular showed that each unit increase of park visits per week in a population was associated with a unit decrease in stress. But it's noted that paradoxically, in this study, there were 2 groups, and one was supported with transportation and reminders to go to parks and some facilitation, and the other group was not supported, and they were just directed to participate as they see fit. And the supportive group visited the parks less, even with the reminders, transportation, etc. So there's some suggestion, at least in one study, that perhaps folks like to have their own control and autonomy in the activities they engage in. So another reason why we propose a curriculum to teach people leave no trace principles as an outdoor ethic that can be developed into a part of their identity and their leisure identity through the people they participate with. So leave no trace. We're going to briefly talk about what leave no trace principles are and give some examples of what some of the curriculum might look like to go over with people with aphasia. So next slide, please. The Center for Outdoor Ethics was established in 1994 to promote the responsible enjoyment of outdoor recreation areas. And the focus is on minimum impact skills, so to preserve our natural environment and the resources that we all experience and enjoy in outdoor recreation. It's a mainstream outdoor ethic. It applies to all outdoor enthusiasts, not specific subgroups, and it's endorsed by most of our land agencies and nonprofits and outfitters and guides in the outdoor recreation field. Slide, please. So the vision of the Leave No Trace Center for Outdoor Ethics is to teach people how to enjoy the outdoors responsibly. And that's what we propose to teach the folks in our program. Next slide, please. So we're going to just talk about the 7 principles briefly because we're not teaching you the curriculum, but just to give you an idea. Some of the main points that we may go over in our curriculum with folks are the first principle is plan ahead and prepare. And so this involves knowing regulations and concerns, preparing for weather, basically getting together with your group of people who you're going to recreate with and making a plan for how you're going to do that responsibly to keep people safe, respect the environment, etc. So this is a chance for people to communicate with each other and practice their communication skills even before they go out into the field and experience some nature-based recreation. Next slide, please. The second principle of Leave No Trace principles are travel and camp on durable surfaces. So this talks about how you move through the environment and avoiding walking on wet vegetation and non-durable surfaces where you may impact erosion. Next slide, please. So we'll give some examples to folks and show what the difference is when people practice Leave No Trace versus when people don't. And so you can see, for instance, the picture on the right is what happens to a trail when people spread out and they don't follow Leave No Trace principles by staying on durable surfaces. Next slide, please. Another example of, you can see, it's a little bit difficult to see, but on the right side, you can see the dotted line is the original trailhead. And because this is the impact of people not following the Leave No Trace principles and walking on non-durable surfaces, you can see the trail erosion. Number 3 is dispose of waste properly. I mean, this is the pack it in, pack it out, just taking care of the environment and cleaning up trash and cleaning up trash and making the environment look better than when you than before you got there is part of this as well. Next slide. And some examples of what it can look like if folks don't take care of it. Principle number 4 is about leave what you find. We want to leave those nature artifacts that we enjoy and see on the trail for others to enjoy in the future, and also for our friends that rely on some of those things for their needs. Number 5 is minimize campfire impacts. And next slide. Some examples of what can happen if people do not. So exposing roots and damaging trees through the root systems and leaving trash behind is a concern. Slide. Respecting wildlife is principle number 6, which I think is pretty self-explanatory. And the next slide has a couple of fun graphics about that. And then the final principle is be considerate of other visitors. And I think this is particularly relevant to the population that we are serving through this proposed curriculum, because we need to teach people and understand that we have all sorts of users out on our trails, and not everyone has the same type of mobility. So yielding to people where appropriate, being courteous and respectful to others as we are experiencing our nature-based recreation. And so the Leave No Trace Center for Outdoor Ethics offers also kind of a planning guide template. And so we can use this with our participants to focus on the principles, reinforce the learning of the curriculum, and help them make a plan for how they're going to engage in the outdoor recreation they choose to, and how they're going to address each of these principles. So again, another opportunity to practice communication skills in a group setting, develop this outdoor ethic, and hopefully instill maybe a new leisure identity in these individuals, especially as they participate in a group setting. Slide. So these are just examples, but it gives you some cues, and then you can write in your own decision-making process based on those principles. So the other piece of our curriculum, besides teaching Leave No Trace principles, is where do we go practice these principles? And one of the ways we are proposing to do that is through community partners and volunteerism through outdoor stewardship and nature-based leisure. So, depending on where you are living, you can find agencies to help you practice leave no trace principles, get individuals that are experiencing aphasia, in our particular instance, involved in trash cleanups, etc., waterway cleanups, and those sorts of programs to go out and practice that outdoor ethic that we've taught them. And then just enjoy some of the nature-based recreation available.
All right, so part of the programming that we're talking about involves volunteerism. It involves volunteerism from the student side to participate in helping guide our participants with aphasia. It involves volunteerism from the aspect of the individual with aphasia and their supportive team, their family, their network, their friends that may come participate with them in the Leave No Trace activity. And so some outcomes that are produced through what we call inclusive volunteerism, we're going to talk about a little bit, but I want you to think about volunteering in your kind of curriculum or your daily life. Most recreation programs involve volunteering, they involve service learning. And most of these outcomes are no different than the experiences you've had, the outcomes that you seek or have experienced as well. And so when we talk about inclusive volunteerism, we're talking mostly about the same outcomes. It just might look a little bit different with some accommodations for individuals with aphasia or other disabilities. So some of the outcomes produced through inclusive volunteerism include things like providing a forum for creating engaging interpersonal relationships. When I volunteer, that's something that I seek from volunteering as well, is creating your sense of community, finding like-minded people, finding peers who may be able to provide resources or other social activities that enhance your life. And so our participants would be seeking similar connections with their peers and supportive teams. Volunteerism also creates opportunities to increase work skills. So a lot of our participants might not work in formal settings where they're necessarily getting paid or have particular job duties, but they might have the desire to work, or they might have particular skills that maybe because of their acquired brain injury, they're working on regaining. And volunteerism could potentially provide that platform to either increase or gain transferable work skills. And the literature in terms of employment and disability really emphasizes how there's a strong connection between purpose and work and motivation to be engaged in your community, to be engaged in the process of building those networks. So it's really important to sort of spotlight the work skills that can come out of volunteerism. Volunteering also offers a venue to establish work history and networks, to create a resume, to create volunteer experience, to list particular duties that individuals may gain through volunteering. If formal work opportunities might not be available at the time, or they're still maybe in a process of figuring out what their work will look like, volunteering can provide an opportunity to enhance those networks. It can also develop career readiness skills, including basic things like attendance, adhering to a schedule, following a routine, being punctual for appointments. And we all know, I think, in that sort of space of coming to class on time maybe, or showing up at your job, or making deadlines, there's a lot of planning and anticipation that comes with attendance, punctuality, creating teamworks, and conflict resolution. So these are all outcomes that can come out of these Leave No Trace volunteer opportunities. There are a lot of reasons why people with disabilities and people with aphasia may not participate in volunteer opportunities. Many of these barriers are sort of programmatic or systematic that are keeping them from maybe volunteering to the level that they desire. So that can be things like maybe an agency has a perceived inability to serve others by agencies. So A lot of times participants may be on the receiving end of services, and those organizations that offer those services don't anticipate or include that those recipients of services may also have a strong desire to serve others and be inclusive of those desires. Avoidant engagement by agencies that lack knowledge regarding accessibility and accommodations. That overlaps a lot with some of the research related to stigma and not having a good understanding of appropriate accessibility and accommodations that may allow for full participation by individuals with aphasia. Transportation issues can prohibit access to volunteer sites, and individuals with disabilities just may be unaware of how to find volunteer opportunities. Again, that's not unique to individuals with aphasia or of varying abilities. That's sort of something that we talk a lot about inherent with volunteering is how do organizations reach people who want to volunteer, and how do those volunteers find those organizations. So some of the benefits once maybe a participant is able to connect with an agency that has volunteer opportunities. Some of the benefits may be access to increased supports, increased networks, developing assets for continued personal growth, increasing ownership in civic engagement and community involvement. So really finding an identity and being a steward of nature and being a steward of your environment can come out of these volunteer opportunities. Enhancing problem-solving skills, working in teams, and planning abilities. For all of us who have been engaged in work in nature or have planned something as simple as a hike, you will probably identify with things rarely go exactly the way they're planned. And so you get a lot of just sort of on-the-fly knowledge and adaptability by engaging in these volunteer opportunities. And then promoting positive attitudes towards people with disabilities in society. That really comes in with our student population as well, and allowing speech-language pathology students and recreational therapy students the platform to interact with their fellow peers and community members. Gives them that sort of unique experience outside of the classroom in the community to have direct interactions with people in a way that is not sort of, educational based, but it's relational based. So you're not talking about disability necessarily, you're talking about the environment, the activity you're engaged in, and you're building those relationships. So some tips for agencies to incorporate inclusive volunteerism. Presume the volunteer work can be completed competently. So in recreational therapy, we talk a lot about being person-centered versus deficit-centered, and this correlates with that. So being person-centered and always assume the best. Assume that the individual will be able to complete the work. Don't automatically look at somebody that has aphasia or another disability and think about what they can't do. Along with that, always use respectful and inclusive language when speaking to people with disabilities, especially in training your volunteers. One of the aspects that Dr. Heggie talked about a lot is communication challenges that may occur with people with aphasia. And part of that is understanding their use of language and understanding how they may be communicating with you differently than, quick question and answer scenarios. So just really taking the time to sort of immerse yourself in that activity, be present, and be respectful of the people that you are volunteering alongside. Plan for success with the volunteer and his or her supporters. Again, just really spending the time to understand the people that you're volunteering with. If somebody has aphasia or a disability, engage their supporters, engage the person, help yourself understand how you can be accommodating directly without being avoidant or making assumptions. And then finally, ask the volunteer and or their supporters what works best for them to overcome challenges. they are, most of the time, because they're experiencing their disability and living with it every day, they're the person that knows what they need. We as educators, or we as therapists or recreational therapy students, are not the experts in what individuals might need for accommodations or just simple help to overcome those challenges. So, of course, we want to reach out and let them know that we're here to support them, but also, trust that they are the best advocate for what they need, and that includes their supporters.
So we have created a proposed curriculum that we're going to utilize when we do implement this pilot program. Again, this is something that we are going to develop in the future. Obviously, with the pandemic right now, we're kind of on a hold, but we are planning on developing and initiating once the floodgates reopen and we're able to be in person. Academically, as a university, currently we're still online, and we'll be in the spring, and so we're hoping this will be a project that we can develop in the summer and then start implementing come the fall. So again, we're going to do a pre-test. We're using the leisure attitude measurement. So for those of you that are rec therapy people, we're going to utilize an assessment out of the Big Red Book, which we feel is most appropriate for this project. We're going to include an introduction to leisure education when we are doing the implementation. Talk about the benefits of nature engagement. We have a in-depth curriculum, which you can also access online through the Leave No Trace website. But we're going to utilize their standardized curriculum. And again, focus on making it aphasia friendly. We're going to talk to them a little bit about volunteerism and which community partners we can access to not only engage in community volunteerism, but on a continuum basis. So we will do it together as a group, and then we're going to hopefully set them up for independence so that they are able to access it in their futures. And then we're going to get out in the community and actually engage in the volunteerism, and then do a post-test where we look at the same assessment and compare and contrast and find out what the outcomes were of the engagement. Next slide. So if we were in person, we would love to hear your questions. Obviously, you're not able to communicate with us effectively through this Zoom. So we are going to provide you with our email addresses. If you do have any questions, concerns, feedback, we would love to hear from you. We really appreciate your time and your willingness to be a part of this session. I know that you had options, and so we appreciate you opting in to have a conversation with us. I'm going to go to the next slide. So here is our contact information. Again, we appreciate your time and your willingness to listen. We hope that this information is helpful, and maybe we'll create some type of structure or foundation for you to implement a nature-based engagement program for individuals with any type of disability. We're just giving you one example of utilizing individuals with aphasia specifically within our environment. So again, thank you so much, and we will look forward to hopefully hearing from you. So anyone want to say goodbye?
Bye, thank you.
Bye, thank you.
Thank you. Thank you.